appetites abdago. I need to see Freddie Maga. Maka all is a weekando. Chukubini webikando. If we reform my Elutaganyaga. One name Kanibolibe. Kelechu. One name Kanibolibe. Kelechu. Okay. Anyway, what time? I don't have your time this time. Ibo yazo, nazwani. Ọlọ́run ló ṣe yìí fún wa. Agbára wa kọ́rara. Ọlọ́run ló ṣe yìí fún wa. Agbára wa kọ́rara. LAUTECH is ready. We're gathered together. The harvest is ready to gather. These colors are shining. Faculties professing. The champions are matching. Keep standing. Oh, see the spectrum. This is LAUTECH, the brightest
visitors to the university from Oyo State and the state of Osun, the campus choir to welcome you all to this auspicious occasion. Just looking around you, everything looks so beautiful. 25, we're coming together, rejoicing. The visitors to the university from Oyo State and the state of Osun, our gentleman chancellor and the amiable pro-chancellor, this so friendly vice chancellor and his team of principal officers, all royal heads and guests of honor here present, great workers here at the university, and all greatest LAUTEChites. It's just the pleasure of the LAUTECH campus choir to welcome you all to this auspicious occasion. Just looking around you, everything looks so beautiful. Now you know that you're already here on the campus. This is LAUTECH. We are great. We are unique. Welcome home to the campus. We're gathered together. The harvest is ready to gather. These colors are shining, faculties professing, the champions are matching, keep standing. Great LAUTECH is ready, we're gathered together. The harvest is ready to gather. These colors are shining, faculties professing, the champions are matching, keep standing. Oh, see the spectrum. This is LAUTECH, the brightest rays. We are the greatest. They silver jubilee, already 25. We're coming together, rejoicing. It's just the pleasure of the LAUTECH campus choir to welcome you all to this auspicious occasion. Just looking around you, everything looks so beautiful. Now you know that you're already here on the campus. This is LAUTECH. We are great. We are unique. Welcome home to the campus. We are great. We are unique. Welcome home to the campus. We're gathered together. The harvest is ready to gather. These colors are shining, faculties professing, the champions are matching, keep standing. Great LAUTECH is ready, we're gathered together. The harvest is ready to gather. These colors are shining, faculties professing, the champions are matching, keep standing. Oh, see the spectrum. This is LAUTECH, the brightest rays. We are the greatest. silver jubilee, already 25. We're coming together, rejoicing. It's just the pleasure of the LAUTECH Campus Choir to welcome you all to this auspicious occasion. Just looking around you, everything looks so beautiful. Now you know that you're already here on the campus. This is LAUTECH. We are great.
Good morning,
We are
distinguished
unique.
guests,
Welcome home.
ladies and gentlemen. Please let us rise for the academic session to come in. Please let us rise.
This lovely LAUTECH, you've kept the promise. Now we're singing, all dressed in splendor, as your promise again is kept. Oh, dear sweet rainbow, allure my feelings, make so timeless. One race for zenith, we together began one day. You led me on as we've come this
Please
far.
let us be seated. Good morning, erudite professors, our very distinguished guests, friends of LAUTECH. We appreciate you for coming to this event, which is the 44th inaugural lecture of the LAUTECH Akintola University of Technology here in Ogbomoso. This morning, it is my pleasure to inform you that the topic of today's lecture will be access to medical imaging, breast cancer and stroke, a stitch in time saves 9. And it will be delivered by distinguished professor of diagnostic radiology, Professor Temitope Olugbenga Bello. At this point, it is my pleasure to invite the registrar of the university, Dr. Kayode Akindele Ogunleye, to come to the podium to invite the VC to read the citation of the lecturer.
The acting Vice Chancellor, the inaugural lecturers, deans, and provosts, everybody present for this 44th inaugural lecture. It is my distinguished pleasure and honor to invite the acting Vice Chancellor to declare the 44th inaugural lecture open and also read the citation of the inaugural lecturer, Professor Temitope Olugbenga Bello. Acting Vice Chancellor, sir.
Thank you very much. I want to sincerely, on behalf of the university, the management, staff, students of LAUTECH Akintola University of Technology, LAUTECH, declare open this inaugural lecture, the 44th one, by Professor Temitope Olugbenga Bello. Open. Professor Temitope Olugbenga Bello, our inaugural lecturer of today, is a teacher of teachers, a scholar of international repute, a renowned radiologist and physician, humanitarian, and astute administrator. Temitope Olugbenga Bello was born almost 6 decades ago to the family of Mr. Christopher Sunday Bello and Mrs. Alice Olufunke Bello of Arigidi Akoko, Ondo State, Nigeria. His educational journey started in 1975 at the Trinity Nursery and Primary School in Ilorin for primary education, which was completed at the University of Ilorin Primary School, Ilorin, in 1980. He thereafter proceeded to Titcombe College, Egbe, Kogi State, where he obtained the West African School Certificate in 1985. He gained admission into the University of Ilorin in the same year to study medicine and surgery and graduated in the year 1991. His mandatory one-year internship was at the University of Ilorin Teaching Hospital, Ilorin, and the National Youth Service at the Ondo State Investment Company in Akure in the year 1993. In furtherance of his pursuit of knowledge, today's inaugural lecturer returned to the University of Ilorin for postgraduate training in radiology and was awarded the fellowship of the National Postgraduate Medical College of Nigeria, Faculty of Radiology, and the fellowship of the West African Postgraduate Medical College, Faculty of Radiology, in 2001. He obtained a master's degree in public administration from the Obafemi Awolowo University, Ile-Ife, in 2007. Temitope Bello joined the services of LAUTECH University of Technology, Ogbomoso, in 2001 as Lecturer 1, and by dint of hard work, rose through the rank until he was promoted to the position of Professor of Radiology in the year 2010. He has contributed immensely to LAUTECH as a lecturer and researcher, and in his capacity as head of Department of Radiology and faculty and faculty senior representative on the postgraduate school board. The development of the first professional master's program can be attributed to this erudite scholar. His versatility was displayed in his role as an associate lecturer of medical physics in the Department of Biomedical Laboratory Science from 2005 to 2014, and the Department of Anatomy from 2013 to 2015, respectively. The first professor of radiology of this unique university also made LAUTECH proud by distinguishing himself during his tenure as consultant radiologist and director of magnetic resonance imaging at Al Kun Funda Hospital, Saudi Arabia. This distinguished physician is a prolific writer who has contributed over 70 publications in learned journals on his research interest of neuroimaging, musculoskeletal imaging, and breast imaging, to mention a few. To his credit is the training of hundreds of medical students, many radiology consultants, and doctorate degree holders. His list of recognitions and awards include the Derrick Hardwood Nash Fellowship for Clinical Training in Interventional Radiology at St. Louis, Missouri, USA in 2010. Doctor of Medicine degree from the National Postgraduate Medical College of Nigeria, among others. Today's inaugural lecturer is an examiner at the West African Postgraduate College and National Postgraduate Medical College of Nigeria. He is also in high demand as a member of Nigeria University Commission's visitation panels to about a dozen universities in Nigeria. He is a member of many professional bodies and was the first vice president of the Association of Radiologists in Nigeria. Professor Temitope Bello, a devout Christian and minister of the Redeemed Christian Church of God, is happily married to Professor Olugbenga Bello, a public health physician, and the union is blessed with wonderful children. Ladies and gentlemen, shall we welcome this erudite scholar and first professor of radiology of this record-setting university, Professor Temitope Olugbenga Bello, as he presents the 44th inaugural lecture of the Pace-Setter University. Thank you.
The Acting Vice Chancellor, Sir, Professor M. Eliasu, Deputy Vice Chancellor, other Vice Chancellors present and past, the Registrar, Dr. K.A. Ogunleye, the Bursar, the University Librarian, other Principal Officers of the University, the Chairman, Committee of Provosts and Deans, the Provost College of Health Sciences, Deans of Faculties, Postgraduate School and Student Affairs, professors and other members of Senate of LAUTECH, heads of department and director of units, members of staff of LAUTECH, Your Royal Highnesses, distinguished guests and family members, gentlemen of the press, greatest LAUTEChites, distinguished ladies and gentlemen. I welcome you all to this inaugural lecture and give glory to the Almighty God for the opportunity to deliver the 44th inaugural lecture of the Ladoke Akintola University of Technology. The lecture is the first from the Department of Radiology and the sixth from the College of Health Sciences. I'm honored and privileged to be allowed to deliver this inaugural lecture titled Access to Medical Imaging, Breast Cancer and Stroke. A stitch in time saves 9. Today's inaugural lecture is a platform for me to share with my colleagues and the public my academic works, contribution to radiology body of knowledge, and its impacts on the society. I chose the topic, access to medical imaging, breast cancer and stroke, a stitch in time saves 9 for 3 reasons. Firstly, medical imaging unique ability to see inside the human body is essential to make accurate early diagnosis of disease before the onset of complications. Secondly, this unique ability is also essential in screening apparently healthy individuals. And thirdly, access to medical imaging is poor in our nation, leading to late presentation and complications. My intention in this lecture is to highlight the radiology's central role in making early diagnosis in the management of breast cancer and stroke, and the difficulty the average Nigerian faces in assessing medical imaging facilities. What is radiology? Diagnostic radiology is one of the youngest branches of medicine, Radiology is a medical specialty that uses imaging modalities to diagnose and treat diseases. Radiological science's primary aim is to see inside the human body, understand its physiological or pathological processes, and make an accurate clinical judgment without surgery or invasive procedures. This skill combines the knowledge of anatomy, pathology, medical physics, and clinical medicine. Therefore, the radiologist can diagnose a disease before it becomes clinically apparent, giving the attending physician the time and the opportunity to institute early interventions. The radiologist is regarded as a consultant's consultant because specialists in other medical fields often depend on radiological diagnosis for comprehensive management of their patients. On November 8, 1895, William Röntgen accidentally discovered radiation that can penetrate the human tissue and took the first human image, which was his wife's hand. Not knowing what to call this discovery, he termed it X-rays. X means unknown. And that first radiograph was the beginning of the radiological sciences. For his heroic efforts, he was awarded the Nobel Prize in Physics in 1901. About 17 years later, in 1913, Albert Salomon commenced the research leading to mammography eventual development. It took another 80 years for another landmark development in radiology in 1972, when Gottfried Hunsfeld and Alan Komak introduced the computerized CT scanner. Another giant stride was made in 1977, when Ray Damadian built the first commercial MRI scanner. The term medical imaging comprises of radiology, which uses technique of X-rays. We have ultrasonography, the use of sound waves. We have MRI, the use of magnetic and radio waves. And of course, we have nuclear medicine. Medical imaging is a more encompassing term than radiology, but worldwide and traditionally, the discipline is still referred to as radiology. Radiology, like most medical specialties in Nigeria, started at the University College Hospital, Ibadan. The first Nigerian professors of radiology were the late Professor T.M. Kolawole, late Professor S.B. Lagundoye, and late Professor B.C. Umera. I was fortunate to have part of my training under Professor S.B. Lagundoye, popularly referred to as the Nigerian Doyen of Radiology. He was a great mentor and teacher. The founding fathers established excellent standards for the postgraduate training of doctors in radiology in Nigeria and West Africa. My choice of radiology as specialty. What made me choose diagnostic radiology? It is a difficult question. Even today, I'm not sure I have a ready answer. At the University of Ilorin Medical School, radiology was part of an 8-week course in surgery, and so exposure was limited. While working as a medical officer in a private hospital in Akure, Ondo State in 1994, the hospital bought ultrasound and X-ray equipment to improve patient care. Unfortunately, we are not able to use the equipment and always refer patients to other hospitals for ultrasound and radiological services. I also observed that the radiologist's clinical report and diagnosis were critical components for our patient appropriate management. In my opinion, that was my first introduction to clinical radiology, and it spurred me to undertake my postgraduate training in radiology. I applied and was admitted for the postgraduate medical training program in radiology at the University of Ilorin in April 1996 and graduated with the fellowship of both the National Postgraduate and the West African Postgraduate Medical College in 2001. I had great teachers in person of the erudite Professor Donald Inze and Professor Funsho Komolafe. Dr. Ms. Olatunji was my ultrasound tutor. She gave me access to her books and was patient in teaching a young novice like me the rudiments of radiology. Those books were quite expensive relative to our salaries then, and I essentially read her books for the first 3 years. My teachers imbibed in me the spirit of keenness of mind necessary for academic excellence and love for hard work. In 2005, I undertook a master's degree program in public administration at the Obafemi Awolowo University in Ile-Ife, and in 2009, I had clinical exposure in interventional radiology at the Mallinckrodt Institute, St. Louis, Missouri, USA. In January 2021, I was awarded the Doctor of Medicine degree from the National Postgraduate Medical College of Nigeria. Mr. Vice Chancellor, sir, my area of focus are breast imaging and neuroimaging. I focused on breast disease, specifically breast cancer and its prevention, because the health of women is a true reflection of the nation's health. My second area of focus is neuroimaging, specifically on cerebrovascular disease. Breast cancer and cerebrovascular disease have one thing in common. Early detection is the key to successful management and prevention of debilitating disease. Breast imaging early diagnosis by mammography. Human beings are the only mammals with permanent breast. And breast cancer can also affect males, but it predominantly affects females. Breast cancer is a scourge of women worldwide, and especially in African women. Recent reports indicate that breast cancer cases are increasing in Africa. The statistics are frightening because more than 1 million new cases are diagnosed annually, and about 4.4 million women live with the disease worldwide. In Africa alone, the number of reported deaths from breast cancer is over 400,000 annually, Adeloye et al. 2018. The most significant risk for developing breast cancer are female gender and age. There is nothing one can do about being a woman or aging. They are physiological process. Therefore, early diagnosis is the key to therapeutic intervention and maintenance of good quality of life. All breast lumps should be checked by self-breast examination, clinical breast examination, and mammography. A fundamental examination for early detection is mammography, an imaging modality that uses low-dose X-rays to image the breast. With this machine, it is possible to detect breast cancer very early as 5 to 10 years before it becomes clinically apparent. Awareness, knowledge, and perception of breast cancer and practice of mammography. A major challenge in Nigeria is the late presentation of women with signs of breast disease. Most researchers have observed this phenomenon. The significant reasons ascribed include ignorance, lack of healthcare access, and lack of professionals with appropriate skill. To assess reasons for late presentation, we conducted a descriptive cross-sectional study among women to evaluate their awareness, knowledge, and perception. Bello et al. 2011. Our study showed that about 70% of respondents were aware of breast cancer, but their knowledge and perception of the disease were poor. Also, the respondent score for practice of self-breast and clinical breast examination were also low. For instance, a significant number of women perceived that breast cancer can be caused by spiritual attack or trauma. We concluded that wrong perception may contribute to the poor health-seeking behavior of our women. Most researchers in Nigeria have attributed the late presentation of breast cancer to lack of awareness, as I've said. In a way, this may be true, because the percentage of women with awareness and knowledge of breast cancer is low compared to what obtains in Europe or North America. Recent research, however, suggests that the level of awareness is rising in Africa. Our study on awareness and perception also came to a similar conclusion, but we felt that this conclusion appeared too simple to explain breast health-seeking behavior in southwest Nigeria. And therefore, we formulated a new hypothesis to test the relationship between the knowledge and practice of breast cancer screening. In this new study, our subjects were female nurses and non-health professional women. Our premise was that female nurses will possess more excellent knowledge and practice than women without a medical background, which we refer to as non-medical or lay women. As expected, our results show that the knowledge and awareness of breast cancer were higher in nurses compared to the lay women. We also observed that the practice of self-breast examination was significantly higher in nurses than lay women, which suggested that higher knowledge may lead to better breast health practices. Mr. Vice Chancellor, sir, we were surprised to note that the percentage of women above the age of 35 that had done mammography was similar in both groups. So this study shows that knowledge and awareness may not equate with the best practice for mammography in our environment. In addition, the majority of the women stated that fear of the disease, lack of mammographic machines, and cost of the procedures were the main reasons for their poor health seeking behavior of mammography. On the slide, you might see other things like dependence on traditional medicine, absent government participation. These are some of the reasons why women have not been performing screening mammography. We also decided to study the role of men in early detection of breast cancer. Men have a key role to play in the detection of their spouse's breast lumps. And most authors have concluded that men influence their spouse's health behavior. However, the role of men in detection of their spouse's breast lump is largely unexplored. We examined the role of men in early detection of breast cancer at DOT et al. 2011. Our study shows a high awareness of female breast cancer among married men. In similar studies, the inclusion of men as facilitators in intervention programs improves compliance with and confidence in breast self-examination. So recent studies have shown that the level of spouse education affects breast disease awareness and health-seeking behavior. Our study shows that educated men are more willing to encourage their wives to go for their yearly mammograms. Now we decided to look at the role of physicians in referring patients for mammography. We believe that primary care physicians have an important role in educating and referring women for mammography. It is plausible that most women usually listen to their doctor's advice, and we studied physician attitudes and practice to breast cancer screening. Our study revealed that 50% of physicians, more than 50% of physicians, do not refer patients for routine mammogram. Bello et al. 2007. In contrast, in most developed nations, it is a practice that asymptomatic women between the ages of 40 and 45 are referred by their primary care physician for annual mammography. This implies that primary care physicians also influence the low turnout of women for screening mammography in our environment. Breast cancer's radiographic pattern on screening mammography. Mr. Vice Chancellor, sir, breast cancer is not one single disease. There are various subtypes, and their behavior and presentations vary worldwide. Breast cancer shows racial and genetic differences in clinical presentation. For instance, specific gene mutations make women from the same family susceptible to developing cancer. A mutation in the BRCA1 gene increases the breast cancer risk by 87%. Also, a close relative with breast cancer, especially a first-degree relative, increases the risk of developing breast cancer. In developed nations, first-degree relatives of women with cancer are offered genetic tests to determine their risk probability of developing breast cancer. Some of these women have opted for bilateral preventive removal of their breast. According to the WHO, based on histomorphology and growth patterns alone, there are over 21 histological types of breast cancer that differ in risk factors, presentation, response to treatment, and outcomes. In Africa, it is predominantly a disease affecting women in their mid-40s compared to Caucasians. For instance, breast cancer peak in Nigerian women is about a decade earlier than Caucasians. In addition to occurring earlier in blacks, breast cancers are more aggressive and the mortality rate is higher. A case in point was a 22-year-old girl that presented in our hospital with a very aggressive form of breast cancer. The lady subsequently developed metastasis, that is cancer spread, and died within 6 months of presentation. This is a figure 10 here showing the computerized tomography, and you can see some hyperdense areas within the brain, and that's evidence of affectation of the brain by the breast cancer. The key role of screening mammography. Mammography is classified into 2 subtypes, screening and diagnostic. Screening mammography is more difficult to sustain in our environment than diagnostic mammography. Screening involves asymptomatic women, whereas diagnostic mammogram refers to those with symptoms and signs of disease. In some cases of diagnostic mammogram, the condition may have advanced and spread to other parts of the body with the subsequent reduction in the 5-year survival rate. Breast cancer must be detected at an early stage to ensure good quality of life. And most of the studies in our region have been on diagnostic mammogram, and the reports do not reflect the prevalence of breast cancer in our society. Now, having looked through all this research, one thing that is sure is that our women have low awareness. The physicians are not referring, and it looks as if they don't have access to these to mammographic facilities. So we decided to have an interventional procedure. And what we did was that after a thorough analysis, our team designed an intervention program. And we did the intervention to see that if given the right condition, women can have a more positive response to mammography. In this pioneering work, which was exclusively on screening mammogram, one of the first in the sub-Saharan Africa, we employed a massive public enlightenment campaign to get our message to the public. I went on Radio Osun on a popular Yoruba talk show called Eroya. During the program, we educated women on the importance of early detection of breast cancer. In addition, we announced that women could book their mammograms from the comfort of their homes using their mobile phone. We went further with the assistance of the then governor's wife, Chief Ms. Oyola, organized a breast health program with representatives of women from all the local governments of the state. The cost of breast mammogram was reduced from about 8,000 to 3,000 naira with the support of the LAUTECH Teaching Hospital. In addition, all the women with any detectable mass were offered free breast ultrasonography, free wire localization of the suspected mass, and open biopsy if necessary. Mr. Vice Chancellor, sir, women came from all the major southwest cities of Nigeria, including Lagos, for the screening program. During this program, more than 4,000 women had mammograph for the first time. Mammography features in Nigerian women. Our observations in this pilot intervention scheme was published in our report titled Screening Mammographic Features in Nigerian Women, Bello et al. 2012. We detailed the type of breast density in Nigerian women, demographics, and mammography findings. It is interesting to note that more than 96% of subjects had screening mammography for the first time. Now, for our women here, it's very important to know the type of breast density that someone has when you go for a screening or a diagnostic mammography test. Because breast varies in densities, and all these densities are normal. We classify them from A, B, C, and D. Now, most women between the age of 42 and 51 have breast density type A and B, which is mostly fatty. Now, breast density type C and D are dense, and very dense breasts can mask pathological lesions, giving rise to false negative results. Now, what do I mean? Now, if the normal breast density is sort of whitish, okay? And when it's like that, if you have a mass lesion inside, it might be very difficult for the doctor to see. Classification of breast lesion on screening mammography. As stated earlier, mammography can detect abnormalities in the breast before becoming a clinical concern. In our pioneering work, about 12% had positive results on mammography, which are mainly masses, lumps, and calcification, or a mixture of masses with calcification. It is a widely accepted opinion that Africans and African Americans tend to present with mass as the first sign of breast disease. Our observation supports this theory. In a complementary study, we re-evaluated the women with breast masses or calcification suspicious of malignancy and localized the mass or calcification by ultrasound-guided wire localization techniques. Afterwards, we performed excisional biopsy and histological diagnosis. Wire localization and obtaining tissue for diagnosis is crucial in the management of breast lumps because benign conditions are common in women aged 30 to 50 and do not increase cancer risk or require treatment. Wire localization is a procedure that uses fine wire to mark the location of a lump prior to excisional biopsy, and this is crucial for non-palpable breast lumps or lesion. A biopsy is a procedure for taking a part of tissue from a living body. The surgeon performs an excisional biopsy, and while the patient is still on the surgical table, the specimen is taken to the radiology department for a specimen mammography. The objective is to ensure that all the suspicious areas are removed with surrounding healthy tissue. At the time of this study, these wires were not readily available. So our team developed a novel technique for breast mass localization using thin, sterilized dental suture. This was the first report of ultrasound-guided wire localization in our environment. A summary of our report is presented in Table 1. And if you look at this table, histology revealed that 3 out of the 10 suspected masses were pre-malignant and subsequently had breast conservation surgery. Now, the story of the woman with invasive lobular carcinoma here was remarkable. And if you look at this table very well, you will realize that these women, most of them are below the age of 40. The woman with invasive lobular carcinoma was a 38-year-old woman who brought her child to the hospital for an unrelated ailment and was informed that the hospital was offering breast cancer screening at mega cost. She had a mammogram which showed an area of pleomorphic calcification, and subsequent result on biopsy was invasive lobular cell carcinoma. She had a modified radical mastectomy, and the quality of life had remained stable. We have 2 other cases, a 39-year-old woman that also had a stage 0 pre-malignant disease. The pre-malignant stage of the disease can remain stable for a long time, but it increases the risk of developing invasive cancer about 7 to 10 times. These women were all offered wide excision of the area of calcification and breast conservation surgery. Ladies and gentlemen, these women had no symptoms. And in a period of 6 months, we identified 10 women with suspicious mammographic pathology, out of which 3 were pre-malignant or malignant. Our studies reiterated the importance of early diagnosis, which is the only viable option for the treatment of breast cancer. Health education has been proposed as a method to aid clinical presentation. However, in Africa, health education is usually not backed with access to imaging facilities and therefore necessary medical experts to make an early diagnosis and institute therapy. This may be responsible for the failure of health education to promote early breast cancer diagnosis in sub-Saharan Africa. Our report was one of the earliest from sub-Saharan Africa, proving that it's possible to detect breast cancer early and perform breast conservation surgery using a multidisciplinary team approach. Our researches prove beyond doubt that African women are deeply interested in their well-being, provided there is access to medical facilities and experts. Artificial intelligence and breast cancer. Breast mammograms can be very difficult to read, and breast radiologists in the United States, for instance, have some of the highest litigation rates. Artificial intelligence is used in reporting and recognizing patterns on digital imaging. It's a branch of computer science involved with developing software that can perform cognitive tasks that would normally require human effort. The primary goal of CAD is to interpret digital images and helps in detection of lesions. At the Ladoke Akintola University of Technology, the Department of Engineering and Computer Science, with support from Radiology Department, have developed 2 software programs to aid doctors in detecting breast lesion. The first was a software for editing digital breast image. This software is capable of extracting the pectoral muscles and other artifacts on a mammogram. That's Ojo Adepoju et al. 2014. The pectoral muscles represents a predominant dense area in the mediolateral oblique views of mammogram and can therefore obscure a breast mass. In addition, we developed a second program capable of categorizing normal breast density and also for detecting lesions within the breast. The developed software achieved a 90% sensitivity and 85% overall accuracy. I'm part of the research team dedicated to the use of artificial intelligence in medical diagnostics. Our research group, known as the Signal Processing Instrumentation and Control, is based here in Ogbomoso. One of our cardinal objectives now is to develop a commercial version of the CAD mammographic software. Mortality and morbidity of breast cancer. The mortality rate or death attributed to breast cancer is reducing in developed countries while rising in developing countries. The most common cause of death is cancer spread to various organs, accounting for about 35% of all deaths. And the most common metastases are the endocrine organs. In Nigerian women, the high mortality can be attributed to the high financial costs associated with late presentation. LAUTECH et al. 2016 observed that the mortality rate of metastatic breast cancer ranges from 10 to 15% in Nigeria, making breast cancer one of the most important causes of female deaths in Nigeria. The average estimated cost for treatment for metastatic breast cancer in Nigeria range from 150,000 to 400,000 naira per month. This amount is higher than the mean income of most working class women. To optimize our women's health, we must focus on early diagnosis and treatment as a strategy to achieve good quality of life and a 5-year survival at reasonable cost. My second area of focus is neuroimaging. The human brain is more complex than any other structure in the world. It is a marvel of creation. It controls all the functions of the body and is the seat of the mind, the soul, intelligence, creativity, memory, and emotions. In addition, the brain controls reflexes and the basic life functions such as heart rate, breathing, and blood pressure. The brain consumes more glucose and oxygen supply than other structures in the body relative to its mass. A drastic shortage of glucose and oxygen below a critical value can lead to irreversible injury to the brain. Stroke is rapidly developing clinical signs of focal or global disturbance of cerebral functions lasting for more than 24 hours or leading to death, with no apparent cause other than vascular in origin. Stroke is common in our society, affecting all age groups, including children and both genders. However, it is commoner in males and the elderly. The brain begins to die within minutes of the absence of blood supply. Therefore, early diagnosis is crucial. In the United States, stroke is the leading cause of death, and the warning signs of stroke includes weakness on one side of the body, numbness of the face, sudden confusion, trouble speaking, visual problems, and dizziness. Africans are more prone to stroke compared to Caucasians, and cerebrovascular disease is a leading cause of morbidity and mortality in Nigeria. Owolabi et al. 2015. In many communities in Nigeria, stroke is shrouded in superstitious belief. Perceived causes of stroke among a subset of Nigeria include overloading the brain, spiritual battle, demonic attacks, loneliness, and bitterness. In these communities, affected persons most often visit herbalists and spiritual houses rather than hospitals. These patients eventually come to the hospital where there is no improvement, and many come in a moribund state, making a positive outcome very difficult. In addition, in many Yoruba communities, a man who develops stroke during sexual activity can be wrongly attributed to an occultic phenomenon called magun. Physiological risks for stroke, especially in Africa, include things like hypertension, others are high cholesterol levels, diabetes mellitus, smoking, and obesity. By appropriate lifestyle adjustment, it is possible to reduce the risk of developing stroke in our environment. This includes monitoring blood sugar levels, monitoring blood pressures. In other words, stroke is preventable to a reasonable extent. The critical factor in the management of stroke is timely intervention. The early diagnosis and classification of stroke into hemorrhagic or ischemic is the basis of early intervention. Hemorrhagic stroke is sudden, usually fatal, and patients are managed conservatively or via interventional vascular procedures. However, ischemic stroke is technically more gradual, and early intervention can prevent major irreversible complications. Ischemic stroke depends on the size of the vessels involved. If the vessels are large, it can lead to sudden loss of consciousness, but if the vessels are small at times, the patient may be symptomless. Vascular intervention, either through radiological guided procedure or surgery, is appropriate for ischemic stroke, affecting bigger vessels to prevent permanent disabilities. Non-contrast computerized tomography, CT, and magnetic resonance imaging of the brain are the standard imaging modality for acute stroke evaluation. However, non-contrast computerized axial tomography is usually the first imaging modality for acute evaluation because it is relatively widely accessible compared to MRI. It is convenient, it has a short imaging time, and is sensitive for detection of bleeding. These imaging modalities are not readily available in Nigeria, so the typical presentation is usually late. It may take weeks for most suspected cases to obtain a CT scan, and by then it is too late to salvage the brain. A CT scan is a basic equipment in a 50-bed hospitals in most developed nations, but it's still a luxury in Nigeria and out of reach for millions of our people. Bello TO, in a review of the first 100 cases presenting a newly installed computerized unit, showed that the most common request was for brain CT, and the most common finding was cerebrovascular disease. The human brain is complex, and each region has its specific roles and function. This complexity is responsible for the myriad presentation of stroke. In our local review of patients with clinical suspicion of stroke, computerized tomography correctly diagnosed about 75% of cases as stroke, and the rest were due to other pathologies masquerading as stroke. Furthermore, we were able to locate the region of the brain and match the symptoms with the region of injured brain, TO Bello 2010. We also confirmed that ischemic stroke was more common in our environment than hemorrhagic stroke. In our environment, ischemic stroke constitutes about 66%. But in Europe and America, ischemic stroke is comprised of about 70 to 85%. Again, this has significant prognostic implications. As stated earlier, ischemic strokes are usually less fatal than hemorrhagic strokes and more amenable to intervention. Mr. Acting Vice Chancellor, sir, stroke incidence is 5 years, and that hypertension was the main predisposing factor. Unfortunately, hemorrhagic CVD constituted about 50% of our cases, which is more challenging to manage successfully in our environment. In this study, only 3 had CT examinations and not within the first 24 hours of the incident. Consequently, these young adults developed multiple complications of the disease. Our study mortality was about 30%, which shows that 1 in every 3 young adults with CVD died. The high death rate may be attributable to delay in diagnosis and failure to institute timely therapy. Another group at risk of strokes are young children with sickle cell disease. This group is highly predisposed to ischemic stroke of the major vessels. Verduzco and Nathan, 2009. Nigeria has the highest burden of sickle cell patients globally, and the incidence of stroke in this group of patients range between 65 to 70%. Pediatric stroke leads to significant morbidity and mortality. Most of the stroke occur between the age of 2 to 9 years, leading to learning disability, seizure disorder, and motor disability. Given the onset of impairment during childhood and the impact on the quality of life for the child and family, the economic and emotional costs to society are enormous. Recently, I focused my attention on prevention of stroke in young adults and children with sickle cell disease because of its high negative economic impact and physical limitation. The first step was that we established a stroke team comprising of radiologists, neurologists, and pediatricians. The second step was that we identified patients at risk. Then finally, using clinical evaluation and imaging methods, we assessed patients and determined their probability of developing stroke in the future. Prevention of stroke and institution of early therapy is the mainstay of management in the young adults and children. Evaluating the extracranial section of the major vessels of the brain via duplex ultrasonography. Duplex ultrasound is a specialized interpretation of ultrasound waves, and it refers to the visualization, utilization, and application of ultrasound waves to interpret movement of blood within vessels and tissues. Duplex ultrasonography can quantify flow and is invaluable in the management of CVD, especially assessment of the carotid arteries in suspected stroke patients. Bello et al. 2016 established baseline local values for the total cerebral blood flow in adult Nigerians indirectly by performing carotid and vertebral artery ultrasound. Accurate knowledge of the normal anatomy of the vessels and velocity of blood flow to the brain helps in the management of CVD. For instance, if a patient has a narrowed and diseased carotid artery, the risk of developing ischemic stroke increases. Therefore, in such patients, it is imperative to start therapy before the clinical symptoms begin. In pediatric sickle cell disease, prevention of stroke is the hallmark of management. Again, ultrasound waves are used to interrogate the vessels. Transcranial Doppler and transcranial color Doppler are imaging techniques for evaluating the major vessels in the brain. The two ultrasound-based methods can predict the probability of developing stroke and identify those patients with the highest risk of stroke. TCD is a non-imaging technique. It provides information in form of a graph, whereas in TCCD, you can identify vessels and take a more appropriate and accurate measurement. However, TCD was the method used for clinical trials and is currently the gold standard. Currently in LAUTECH Teaching Hospital, we created a neurology clinic for sickle cell patients. The personnel comprised of a team of radiologists and pediatricians using transcranial color duplex Doppler to evaluate sickle cell children at risk of developing stroke. We perform this examination at no extra cost to these vulnerable patients as one of our major contributions to reduction of childhood stroke in our environment. As stated earlier, TCCD technique allows direct visualization of the arteries of the brain. We are currently working on the reliability of the TCCD compared with the established method of the non-imaging TCD in Nigerians. The results are encouraging, and we have screened over 400 patients and have successfully identified patients at risk of developing stroke. Subjects with sickle cell disease manifest increase in peak systolic velocity of the major brain vessels compared with controls, and values above a critical point are regarded as a potential case of stroke. The sickle cell disease in our study with high risk of stroke were managed with hydroxyurea and blood transfusion to reduce the quantity of the sickle-shaped red blood cells, thereby preventing stroke and reducing morbidity in these young children. Mr. Acting Vice Chancellor, sir, I'm happy to state that our stroke team is working to educate young adults with the aim of reducing the occurrence of stroke in this age group. In addition, we have also reduced the morbidity and mortality of stroke in children from sickle cell disease in Osun and Oyo States, Nigeria. Community service. I was fortunate to serve as a medical consultant to MyCom Cancer Foundation based in Osogbo, Nigeria. Through the foundation, I facilitated the installation of 2 modern mammographic machines at the LAUTECH Teaching Hospital, Osogbo, at a cost of about 35 million naira. As at today, these are the only functioning machines, and in addition, I've given multiple health talks on breast cancer awareness and its early detection in many forums. I've also served as a member on the NUC panel for undergraduate accreditation exercise to more than a dozen universities across the nation. Manpower development and training. When I joined Ladoke Akintola University of Technology Ogbomoso in 2001, the university had no accreditation from the National University Commission of Nigeria for Medical Student Training and no accreditation from the Postgraduate Medical College for postgraduate training in radiology. I was part of the foundation staff responsible for obtaining the NUC accreditation and produced the first batch of LAUTECH medical doctors in 2002. Also, during my tenure as head of department, we got the accreditation of the National Postgraduate Medical College of Nigeria, and in the last 10 years, we have trained and produced over 12 consultant radiologists in our institution. I'm proud to state that our products have been representing our institution excellently. I've also lectured in medical laboratory science and anatomy departments. In addition, I've been involved as co-supervisor for PhD students working on artificial intelligence for medical purpose in computer science and electrical engineering departments of our great university, Ladoke Akintola University of Technology. I'm also currently a senior pastor of the Redeemed Christian Church of God, and I serve as the zonal pastor of the New Song Cathedral in Osogbo. Research. Research is vital to an academic and helps increase the visibility of the university. I've published over 70 papers in national and international peer-reviewed journals. Besides, I review manuscripts for several peer-reviewed journals. I'm on the review board of the West African Journal of Radiology, and I'm also the editor-in-chief of the West African Journal of Ultrasonography. Awards and fellowship. In 2009, I obtained the Derek Harwood Nash Fellowship for Interventional Radiology Training at the Marlin Cross Institute of Radiology, St. Louis, USA. The award is for 3 persons yearly worldwide. The fellowship offered me the opportunity to train in interventional radiology. Interventional radiology uses image guidance to carry out a range of medical procedures and minimally invasive surgical procedures to treat patients. Unfortunately, this aspect of radiology is in infancy in Nigeria. I've also participated in numerous travel fellowships in Asia, Europe, and the United States of America. What are our challenges? Radiologists have experienced a lot of challenges and a lot of innovations. Radiology has experienced a lot of innovation based on advances in technology in the last 20 years. Many of our teaching hospitals do not have functional CT, MRI, or mammography machines. And oftentimes, these machines are either not working optimally or suffer from incessant breakdown. I'm happy to announce to you that at the Ladoke Akintola University Teaching Hospital, we have a 1.5 Tesla MRI. And in the southwest of Nigeria, outside Lagos, we are the only teaching hospital with this functional machine. Also, we have a functional mammography. And for the members of FWACS here, courtesy of the CMD, we have agreed for a reduced fee for mammography for all your members if interested. So hands-on experience in all imaging modality is crucial to a competent radiologist. I was fortunate to work in the Kingdom of Saudi Arabia as head of radiology and director of MRI for 3 years. And it may surprise you that I did more advanced imaging, especially MRI, in 3 years than my previous 17 years in Nigeria. Although we have a national policy on cancer management, most of the important guidelines have not been implemented, thus making the policy ineffective. Most hospitals do not imbibe the principle of creating effective multidisciplinary teams to solve clinical challenges. My recommendation, sir, that one, to the federal government of Nigeria through the Ministry of Health or via any of its agencies should implement the following suggestion. One, aggressively implement the Nigerian National Cancer Control Plan 2018-2022. Install mammographic machines in one hospital in every senatorial district and subsidize breast cancer diagnosis and treatment with the aim of making breast cancer treatment affordable and accessible. Breast cancer should be fully covered by the National Health Insurance Scheme. This is in line with the Nigerian National Cancer Control Plan. And also, we should formulate a national policy on the procurement, installation, and maintenance of radiologic equipment to ensure that teaching hospitals are functional computerized scanners and ultrasound machines. The management of LAUTECH teaching hospitals with the relevant departments should create stroke teams and develop local policy for suspected stroke patients' clinical management. Stroke units tend to manage stroke cases better than the traditional approach to the management of stroke patients. Oyo State government and the governing board of LAUTECH University of Technology teaching hospitals should ensure that the new Department of Radiology in Ogbomoso obtains accreditation from the National and West African Postgraduate Medical Colleges for training in diagnostic and interventional radiology. We also recommend that the LAUTECH University should encourage research in artificial intelligence for medical purpose. Acknowledgements. Mr. Acting Vice Chancellor, sir, distinguished ladies and gentlemen, I give glory to the Almighty God for His love and blessing on my life. In so many ways, I've been divinely favored in life, and especially in my academic career. I appreciate God's kindness to me and my family. I thank everyone who has contributed in one way or another to whom I am today. This inaugural lecture will not be complete if I do not acknowledge the people who made this day a reality. I thank the Acting Vice Chancellor, sir, Professor Eliasu, for the opportunity to deliver this lecture. Thank you, sir. And also the previous Vice Chancellors for creating a conducive environment for intellectual pursuits in our great institution. I thank my parents. I want Daddy and Mommy to stand up, please, for a minute, just for recognition. Thank you, sir. You can please sit down, ma. I thank my parents, Chief Christopher Sunday Bello and Mrs. Alice Olufeke Bello, for being wonderful mentors and guardians. My father is a strict disciplinarian and passionate about quality education. My habit for love of reading was developed at home by watching him read for about 2 hours or more daily. My mother was a primary school teacher, and I followed her to school from about the age of 4. She taught me my first letters. Her classroom was my daycare center. I thank her for her love and encouragement over the years. Both sponsored my education from primary to university level. My father always tells me that I was destined to be a medical doctor from the age of 6. I thank them for their word of encouragement and support. I thank my secondary school principal, Dr. Adewumi, for being a great guardian at Titcomb College, Egbe, Kogi State. I acknowledge my secondary school teachers, especially my further maths teacher, Mr. Finch, for his dedication and passion and encouragement. I thank my teachers in radiology, Professor Funsho Komolafe, Professor D.A. Inze. These two great radiologists supervised my dissertation for the award of the Fellowship of the National Postgraduate College of Nigeria. I thank Professor A. Amole, Dr. Mrs. Olatunji O, Professor Adetiloye, Professor Adeyinka, Professor Ifem Okoye, Professor S. B. Lagundoye, Professor Millicent Obajimi, Professor Ogunshainde O.O., Professor Oguntoyinbo, Professor K.T. Braimo, and Dr. J.S. Abe for being excellent teachers and mentors in radiology. I appreciate my colleagues during the residency training program, Dr. Sunday Erinle, Dr. S.D. Palm, late Dr. Tachi Atume, Professor Suleiman Seidu, Professor Tabari, Professor Adeyo Moye, and Professor O. Oyinloye. Second, special recognition to Professor A.B.O. Omotosho, Professor O.O. Fakeye, and Mr. O. Adeshoba. They were the principal officers at the University of Ilorin Teaching Hospital and gave me the opportunity for postgraduate training in radiology. My special appreciation goes to Professor Akinshola A.A., former Chief Medical Director, Ladoke Akintola University of Technology, Oshogbo. He believed in capacity building and was responsible for equipping the radiology department in 2004 with advanced imaging machines. At that time, LAUTECH Radiology was one of the best radiology departments in the southwest of Nigeria, and physicians from neighboring states referred to our departments. And without him, most of our research works would not have been possible. I thank Professor M.O. Ologunde for believing in me and giving me the privilege and approval for taking up an appointment as Director of MRI Imaging in a tertiary hospital in Saudi Arabia. Special recognition also goes to Professor Gio Okpadijo, the Chief Medical Director of LAUTECH Teaching Hospital, Ogbomoso, Professor A.A. Lasisi, immediate past Chief Medical Director of LAUTECH Teaching Hospital, Oshogbo, now Osun State Teaching Hospital. I thank them for their support. I appreciate all members of staff in the College of Health Sciences, the deans, and HODs for their hard work and dedication to excellence. I appreciate the former acting provost College of Health Science, my very good friend, Professor Femi Fadiora, and the acting dean, Faculty of Clinical Services, Professor Ade Yemi, and the dean of the Faculty of Basic Sciences, Professor Kunle Olowe. I thank my colleagues in the department, Dr. Mrs. T.O. Adeniyi and Professor Aremu A.A. I appreciate the administrative staff of the radiology department for their supportive roles over the years. It has been great working with such a wonderful team. I'm grateful to Professor and Mrs. Emela Adeoti. They are our first family friend when I resumed work at LAUTECH. They made settling down easy for me and my family. I thank members of Oshogbo Tennis Club, especially the president and captain. In my opinion, we are the best tennis club in Nigeria. The love and camaraderie is palpable any day. I thank Professor John Adedapo Ojo, the Department of Electronic and Electrical Engineering, and the CPIC team for the opportunity to work with some of the most brilliant minds in LAUTECH. I appreciate my friend and brother, Dr. Adekunle Michael Olatona, for his love and support. I thank my good friend, Dr. Tala. These are my colleagues in Al-Qunfuda Hospital, Saudi Arabia. I'm grateful to my classmates from medical schools present here today, class of Ilumsa 91. I'm grateful and I thank you sincerely for taking time to grace this occasion. I recognize my friend, Professor S.S. Taiwo, former provost of the College of Health Science, Dr. Yewole Adeoye Olutayo, Dr. Godwin Ogbole, and Dr. Reverend Owolade for helping to edit this lecture. I thank all my friends from Titcombe College, Egbe, class 85 here present. May God continue to preserve our unity in Jesus' name. I appreciate all who came from Ondo State, especially from my hometown, Arigidi Akoko, and members of the Arigidi Development Union. I also appreciate my brothers and sisters, cousins and friends from Omo Ekiti State. I recognize Justice Adekonye Ogumoye, the Daramolas, and the whole Ale family for their great love to me in so many different ways. I thank all the royal fathers and traditional rulers here present. I'm grateful to my sibling, Ms. Shola Bello, Mr. Deji Bello, Toye, Grace, Bamishaye Michael, Ebenezer Doju Telegon. I appreciate my brothers, sisters, nephews, and nieces for coming. God bless you and reward you richly. I sincerely thank and recognize the pastors and friends from the Redeemed Christian Church of God, the pastor in charge of region, provinces, zones, areas, and parishes. Especially, I thank the pastor in charge of province, Pastor Olajide Oluwajobi and his amiable wife, the elders, and the church growth officers. I appreciate the reverends and ministers from the Anglican Church, especially the Vicar of St. Paul Anglican Church, Arigide Akoko, Venerable Dele Olorunkoya, for his daily word of ministration and prayers. I thank my students, most are now consultants in radiology, Dr. Jaiye, Dr. Adekomi, Dr. Beteshola, Dr. Bayomi, Dr. Yedeko, Dr. Mr. Jemakinde, and just a whole long list of them for being part of the journey and their support for this inaugural lecture. My in-laws, the late Pastor Olayiwola Iyonda and Mrs. Beatrice Iyonda, have been a father and mother to me in many ways. I pray God preserve Grandma in good health. I also thank members of the Iyonda family here present. I also appreciate the Big Bamis and the Shotundes for their love. I thank all my family and friends, too numerous to mention, for their physical, moral, and financial support to make today a success. I especially recognize my son, Jesu Darasimi Emmanuel Mufeoluwa, for bringing so much joy into our life. Mr. Acting Vice Chancellor, sir, permit me to introduce my darling wife. Please stand up for recognition. Thank you, ma'am. You can sit down. Professor Mrs. Olugbenga Bello, Adenike Iyanoluwa. She's a strong pillar of support and best friend, a jewel of inestimable value. She's 100% dependable and has made her home to be a house of joy and comfort. Once again, I say a big thanks to her. Mr. Vice Chancellor, sir, distinguished ladies and gentlemen, students and members of LAUTECH community, I thank you for your attendance and rapt attention. May you all be richly blessed. Amen.
On behalf of the university community, I hereby declare this 44th inaugural lecture closed.
Please let's remain standing and listen to this announcement. Professors, members of FWACS, guests of the university, college, academic staff should go to the hall for their refreshment. While students will stay in this hall, they will be adequately served. May we all be blessed.
Oh, dear sweet rainbow, allure my feelings, make so timeless. One race for zenith, we together began one day. You led me on as we've come this far. We fixed our shoulders and determined just to